Yep.
Yep. Okay. Well, everyone, welcome tonight to the ANZRS bi-monthly webinar series. And I'd just like to make a special mention to Dr. Philip Komasi, who is an ENT surgeon in the Solomon Islands in Honiara, we're absolutely thrilled that, Philip, you are able to join us, and hopefully Ella Malatugu will be able to join us too when she's back in Honiara. I'm absolutely honoured to have you both. And tonight's session is going to be talking about establishing an allergy practice in your clinic. And we're absolutely thrilled that Dr. Jessica Tattersall has agreed to give us a talk. I've always loved Jess's talks on allergy. They're very practical, and I always take something away from Jess's talks. But to get down to the nitty-gritty, Jess is actually a fellow of the Royal Australian College of General Practitioners, with quite a lot of ENT experience as well, which makes her very unique. And she also has a Master's of Medicine in Allergic Diseases from the University of Western Sydney. And Jess has also worked as a clinical research fellow at the John Radcliffe Hospital at the Department of Otolaryngology in Oxford. And Jess is basically a medical rhinologist with a really strong focus on allergy. And she has set up her own allergy practice. So we thought no one would be better to discuss this than Jess. So Jess, without any further delay, I'll unshare, and the stage is yours.
Thank you. And thanks again for asking me to give a talk. It's quite an honor to be amongst such great surgeons and experienced surgeons. So yeah, I think the way we've set it up with Raywin and Ray sort of moderating it. If you have any questions, pop them in the chat. Happy to be interrupted during the talk, especially if I'm reinventing the wheel, which I think with these first couple of slides it probably will be. So without further ado, we must start by asking, what do you actually want to achieve by setting up an allergy clinic or service in your practice? Is that looking at a full service clinic like what I do, looking after kids, adults, and having a full service allergy clinic, or just our allergen skin prick testing, recommending the simple AIT done by yourself, a nurse, technician, student, or whoever it is. And once you have that sort of picture in your mind, you move on to the idea of how to set that up model-based. So just like any other practice, you can set it up sessional or proportional billing. Now you've got the benefit as ENT surgeons of having toys that are exciting to at least some allergists like myself who like to play with toys. So that's always good to be able to have scopes on hand and stuff. So that works for me, but everyone's going to have their own thing, and all these above models, as you know, could be very variable and negotiable between you and whoever you have working with you. But probably the more interesting one to a lot of ENTs is the model or salary-based employee, technician, nurse, student, researcher, whoever you'd like to have as a salaried employee, doing your skin prick testing and or spirometry. And you can clinical bill the item numbers, which we'll get to later in the talk. Now, this is probably one of the topics that I was asked to speak about. Who can actually do a skin prick test in Australia and New Zealand, and actually anyone? To be fair, it's not actually specifically qualifications. They don't have to be a nurse. They don't have to have anything specific, except it is recommended they have some training. So there are multiple issues with interpretation, including patient factors, external factors, and there's lots of contraindications to performing a skin prick test that should be, most of it, relative, as long as you know how to manage them. There isn't a published set of standards that is on the ASCIA website, which I've put in an appendix with a few other of the things that I'm sort of referencing, so that you can go back and have a look at those websites and see what I mean. But in order to claim the item, the medical practitioner must review the patient, take the history, order the panel, and attend to the patient to interpret results. So you don't have to actually perform it, but you should be involved in the history taking, the requesting of the panel, and interpreting them. So minimum standards for available equipment on site. It should be performed in a medical setting always. medical practitioners competent to treat systemic allergic reactions.
Jess, you may have frozen. Can you hear us? Can everybody else hear me?
Yes.
Okay.
Yeah.
Okay.
Yes, we can
What
hear.
I might do, everyone, you just bear with me. I might just give Jess a quick call, just so maybe she can move somewhere with better reception. Hang on just a minute.
I can actually see Jess's mouse moving.
Yeah, Jess, if you're able to unmute you, I think you're good to go. If you can
Right.
unmute
Okay.
yourself.
Yeah, I went back onto mute. Okay, got it. So sorry. Again, this is not sure when I actually dropped out, but this is for everybody doing skin prick tests. So this includes people doing food allergens, which is obviously more risky than arrow allergy. So this again is the minimum standards recommended by ASCIA. You know, all the same. This gives you a little bit more information about how to run a test. You know, it should be 2 centimeters apart, interpretation at 15 minutes, how to record it. Big thing is you need a fridge in your office because the allergen extracts need to be stored like vaccines at 2 to 4 degrees Celsius when not in use, and devices appropriate for skin prick testing, which are lancets or multi-tests, which I'll get into in a minute. And they obviously need to be interpreted in the context of the patient's history. So again, this is all in the link and the appendix on the ASCIA document on skin prick testing. So again, what do you need? You need the actual allergens. The link to how do you get them ordered in Australia is in, again, the appendix. A little bit of hoops, but luckily not too many. Prior to 2020, it was all about TGA approval and you had to get special considerations, but not anymore. So that's made it about easier. So, yeah, it's, you know, you need the right device, you need the right recording devices. We use an Excel spreadsheet, but you can, however you're going to record it for the patient. So it's kept on file. So this is what I choose to use in my practice. This is called a multi-test, and each one of these little wells have a different allergen, and you can see on top the well corresponds with what the allergen actually is, so you keep an idea of what's going on. You can have obviously up to 24 panels, 24 allergens there. I only do generally 16, but it's up to your area and what kind of arrow allergens you have where you live. So that's the multi-test. You stick this device in and it goes onto the forearm of the patient like that. It's very quick, which is really good. Because you do 8 of them at a time. The other thing is they're plastic, so they can only actually puncture the skin a certain amount, which makes the reproducibility of them a lot easier, so that each one you know exactly where it's gone into the skin, so you're not accidentally intradermally testing another, which can falsify your results a bit. And if you just have to rock it so you make sure that each one is actually gone in nicely at the right pressure. The other way of doing it is single lancet. This is a picture of a single lancet. So you drop the allergen onto the skin, generally record what it is that you're testing with either 1, 2, 3, 4 or the actual name of the allergen, and you single prick the lancet. Now that's a metal one, so it will require a sharp spin. And again, if you're not pushing with the exact same pressure, you can skew your results by going a bit more intradermally, which you, of course, as the person doing the skin prick test needs to be able to interpret and record that. So what are the highlights of doing skin prick tests? This again is in the document, but I just kind of sort of made it the abridged version. uncontrolled asthma, beta blockers, and pregnancy are relative contraindications, not absolute. So you just have to be cautious with those. Skin needs to be healthy. So patients with eczema, which of course you get with any aeroallergen, allergic rhinitis patients or allergic asthma, need to take special precautions with their interpretations and maybe think about other ways of testing if it's quite uncontrolled eczema. And dermatographism can actually skew the results as well. So you need to take those patients into consideration when you're interpreting the results. The results can be very difficult to interpret in the extremes of ages. So there's evidence to show that atopy actually starts to decrease after the age of 56, roughly 60 years old. And very young can also be quite hard. So the little kitties can often get very small wheals, but really rather large flares. And of course, they may have not turned positive yet, so they can be localized allergy there without the skin prick test being positive. Obviously, the Lancet, as I mentioned, can be variable. Medications do need to be ceased. Antihistamines, certain antidepressants, the older style antipsychotics, and can all be interfere with the test results. Certain things like seasickness medications, which have some antihistamine qualities to them, can also give you false negative readings. This is probably more important for people, like I do my own tests in the rooms. I don't send them out, but if you're actually doing something else while the patient's having their skin prick test done, it does need to be read at the appropriate time, because there's a potential for false or delayed reactions to cause a skew in your results, causing like false positive readings. And interpretation, of course, in patients who've had previous immunotherapy, that doesn't mean that their atopy is going to be gone. So they might be positive with absolutely no clinical relevance. And of course, cross-reactivity. So if you're getting somebody who is temperate grass positive with ryegrass, but not on temperate grass mix, you have to wonder what's going on with your results, because ideally they really should be cross-reactive, and there shouldn't be one negative and one positive. And of course, quality control and interpretation needs to be very standardized as well. You see pluses versus the reading of the actual wheel. And whether you take into consideration the wheel, the flare, and the pseudopods in your recordings is, again, something that just needs to be consistent. So that's what a beautiful, nice-looking skin prick test should look like, with the numbers relating to allergens. However, unfortunately, you often get this, which makes it quite difficult to interpret. And of course, this is obviously a very multi-sensitized patient who's going to be quite difficult to decide on appropriate immunotherapy without costing them to remortgage a house. So what are the pitfalls? The big things with aeroallergens is, does size matter? No, not really. With food, it's obviously something we consider, but not with aeroallergy. You need to also have a very good understanding of what's around you, or if the patient's traveling, what's around them. A positive test may still occur without any clinical symptoms. I see in my practice, being inner city, high density living, we get a lot of patients with cats who have a very strong positive reaction to cats, but have absolutely no clinical reaction around their cats. So we need to make sure that we don't make them get rid of their kitty cats and falsely think that that's contributing to their symptoms. Again, negative tests in the presence of a good history should prompt a consideration of another mechanism, whether that's local allergic rhinitis or non-allergic rhinitis. We'll talk about that a little bit later as well. And negative tests in children does not rule out the possibility of future development of allergy. So I talk about that a little bit later on in the as well. But you know, if they're a young child, they might not have turned skin prick test positive yet. And they also might remain positive post desensitization or natural tolerance. So a good example of that is kids who 85% will outgrow their egg allergy, eating egg every day of their life at 16. If we were to test them again, then most likely will have a small positive result still to egg. That is completely irrelevant. And it's obviously very non-appropriate for the diagnosis of non-IgE mediated reactions, which are intolerances, of course, and non-allergic triggers. So in Australia, skin prick tests are done. Item numbers are but basically between 12000 and 12005. The ones that are probably most used for your purposes would be 12001, which is just the arrow allergens. And then the repeat, if necessary, for whatever reason, they need to be repeated in the same 12-month period. 03, 04, 05 are really sort of food, venom, and drug allergy, so not probably relevant. The MBS has a very similar, which is obviously where Askia got their recommendations that the testing should be done with a medical setting and the medical practitioner competent to read it, a resuscitation available. And when I was still working in New Zealand, I knew a lot of people came in with their skin prick tests done through Path Labs, which is quite convenient and a lot cheaper than the serum specific IgE testing, which is helpful as well, because then you can get your test results without necessarily needing the equipment in your rooms. And so, but this is what I really wanted to then move into with the serum specific IgE testing. So when you think about what you actually want to achieve as far as having an allergy service for your patients, you have to wonder whether maybe investing in a fridge and all the allergens and someone to do them and the lancets and all the consumables, whether it might just be easier for you to have order a blood test. And we used to call these, well, we still call them RAS testing. You will still get a RAS test, your test done if you write RAS. However, it is now a serum specific IgE. And the only relevant reason to say this is that it's actually quite a sensitive and specific test now, as far as the results being quite trustworthy. So there are some pros to it. So there's no risk of systemic reactions with a blood test, aside obviously just from phlebotomy, but can be done without stopping any antihistamines or medications. You can get numerous allergens via serum specific, stuff that you might not even have in your office if you have a normal panel. Like I have researchers at the AMR in Darlinghurst who have mouse and rat epithelia, which I don't keep in our refrigerator to do, so I can order that through a serum specific. It's lab controlled and standardized, so that whole interpretation of results is not open to the practitioner. But of course, they're not instantaneous. They do take a few days to a week or so. And you can get false positive high readings with a high total IgE. And so IgE should be always, total IgE should also be requested at the same time. So when you see patients, you're probably not telling them, or your receptionist might not be telling them to stop their antihistamines 3 to 7 days before coming in. So this way, you don't have to worry about that, because that can obviously interfere with your skin prick tests. So there's some pros and cons to that. And with the serum specific testing, sorry, this went a little bit overlap. That's when animations don't work, but this is just a cut and paste from the Douglas Hanley Moyer in Sydney's IgE testing. It's universal, so even though if you don't have DHM by you, the testing items are pretty universal. So you can write cat dander on it, or you can write E1 and you will still get the same result. But in Australia, at any rate, Medicare will pay for 4 single, 1 panel, 2 mixes, and 2 singles, etc. So they'll pay for 4 per year. But so it's best to be specific. Instead of doing an animal panel for somebody who has 2 dogs at home and has no symptoms related to the dog, there's no point in doing an animal panel. But if they want to know if it's horse or cat, then be specific. H2X is the house dust mite, which unfortunately I covered with my path form, but basically that's going to look at your 2 house dust mites and cockroach. So HX2 is a nice mix for your indoor perennial mite allergens, and knowing your local pollens if I go back, you can see here, grass mix 2 is what I use mostly in Sydney, which covers a lot of the temperates and subtropicals, which you get a bit of a mix of. So if you know what you're looking for, you just know your mixes and you can add them in. And that's just an example of one of my requests. So that would be the total IgE with house dust mite mix, grass 1 mix, A3, which is a cat, and a mold mix 6, which is very commonly common molds for our area. So you can easily order those very specifically and get your answers, which come back with roughly in a week in Sydney at any rate. So once you have your test results, why would you offer your patients immunotherapy? I suppose it is, I now move towards desensitization a bit, because once in a while you get the odd person that says, but my grandfather's on immunotherapy for his melanoma, and that could be quite convincing, because it's not a chemotherapy, it's not an agent like that. So I do say desensitization a bit more these days, but it is the only disease modifying therapy for allergic rhinitis and allergic asthma. It's appropriate when obviously topical therapy is suboptimal or it's not tolerated well. Reduces the need for medications, definitely in allergic rhinitis, but also with asthma, allergic asthma, reducing the need for higher doses of steroids or bringing it down to a lower dose, reducing the risk of hospitalizations and emergency presentations, and also reduces new allergic sensitivity. So in children, or say people under the age of 20, you can reduce the risk of them becoming more multi-sensitized. So if you've got a child if you live in a dust mite endemic area like Sydney, who's just dust mite sensitized at the age of 8, you reduce the risk of them being 18 and full of animal dander and pollen sensitization as well. So it slows that allergic, reducing also the risk of that allergic rhinitis child then becoming asthmatic in it's just basically once you treat their main allergen, can reduce them down to the basic population risk of developing asthma, as opposed to 3 times that, which is what a child with allergic rhinitis has. Recognized guidelines that we tend to follow a little bit more in Australia is the single allergen is recommended, even in a polysensitized patient whom one is clearly responsible for the most intense or bothersome symptoms. So for an example for that, to use my examples in Sydney, is a lot of people will be dust mite and pollen sensitized, but their symptoms are really more aligned with that perennial problem, not really recognized increase in symptoms during the spring pollen season. And often then I would recommend starting with the single allergen before moving on to doing a dual agent. You can always add it later as another treatment. But you do get patients who need parallel therapy. So whether that's house dust mite in an animal like cat or dog, or house dust mite and grass pollen. So you can obviously do that, and it's no problem. It just increases the price. So different types that are available. We're going to talk a little bit about subcutaneous, because it is still a very valid way of giving immunotherapy. Generally, there's a build-up phase. In the one that most commonly is used by Immunotech these days in Australia and New Zealand, it's a 4-week. You can do a rush, but 4 weeks is generally what they get, a weekly injection, and then on to the maintenance phase of monthlies. Minimum of 3 years. Efficacy is very good at the end result, although it is slower to onset, especially compared to the tablet forms. You can get natives or allergoids from the company. I tend to prefer natives personally, but allergoids are safer. You still have the same risks in general practice. Who most of my patients who get subcutaneous are getting it done by their GP. The nurse will give the injection, and they still sit in the waiting room for 30 minutes afterwards, even though there's a lower risk with allergoids. The medication is less expensive, but especially in the post-COVID phase, I'm getting, at least in Sydney, a lot of GPs who are not bulk billing injections, which of course can raise the costs quite considerably. So you do want to warn your patient if they really, really want injections, to make sure their GP is going to bulk bill that, or else the costs will go up. one of the pains with both the drops, oral drops, and the injections is that they need to be ordered in from the company overseas, and it can take 8 or so weeks to come in, especially if you're trying to order around any kind of holiday period like in December. And no health fund rebates in Australia. However, some, when I was working in New Zealand, some would rebate, but often the biggest one, which is Southern Cross, would not. So, you know, some of them had excellent rebatable immunotherapy, but some don't. But in Australia, none of them do for subcutaneous. So sublingual, oral drops versus tablets. The drops again are customizable, which makes them good. We have you know, New South Wales grass mix, Queensland grass mix, things like that, and less systemic risk. So only the first dose is given supervised. They're still ordered from overseas. Just with regards to the companies, I have put that in the appendix as well, linked to the ASCIA website of who actually provides both reagents and immunotherapy to us in Australia, New Zealand. So that's all on in the appendix. They're all a minimum of 3 years. Again, because they're customizable, there's no health fund rebates, at least in Australia. And sometimes it is the only option if the patient doesn't want subcutaneous, they really want oral daily doses, and they want dog immunotherapy or horse immunotherapy. There is no tablet version currently available here for that. So it makes it your only option. The tablets, tablets have been excellent. Been using them at least in my sort of practice in the last since they came out in 2016. The grass pollen ones have obviously been a lot longer than that. They've been around a while. And in when I was again down in the South Island, the birch tablets were fantastic as well. They were not listed, but we could get them on non-approval. Sydney, we can use cat tablets, which are not TGA approved, but if they sign the consent, we can actually access them for the patients. They're daily, non-customizable. However, you get what you get. Low risk of systemic events, so only the first dose, again supervised. Risk is probably with the oral immunotherapies biggest with asthma attacks, which I'll get into in another slide. But anaphylaxis is really not really reported. There's been a couple reports from the US, and so everyone on immunotherapy in the US gets an EpiPen, but that's not commonly done anywhere that I know of in Australia or New Zealand. Minimum 3 years, but really fast onset. You can say to your patients, especially with things like dust mite, within 8 to 10 weeks, they'll be starting to notice a clinical benefit. With grass pollen, we like to start at about 3 to 4 months prior to the grass pollen season. So they actually won't notice the benefit until the season comes, because ideally in 8 to 10 weeks, there's still no pollen about. But that's called pre-seasonal initiation. Yeah, I like to do that about May. Canberra or somewhere like the ACT, you can go into June because the season hits a little bit later. So you just have to know when your pollen is likely to hit in your area and try to get it started for that. And thing in Australia, at any rate, with the health funds, if you've got pharmacy extra, they will cover the tablets. So in rough estimates, when I talk to a patient about the different modes in the costs, in Australia, and roughly the same in New Zealand, it's about $650 a year for injection subcutaneous, about $850 to $900 for the drops, and about $1,200 a year for the tablets, which are roughly $100 a month. So if you're getting about $500 back on your health insurance, pharmacy extra, that actually is going to bring for the patient, which is a good thing if they have it. So managing the side effects, this is probably one of the bigger problems you have when you start patients, is that you got to have someone to manage, because if they end up going to their GPs with local side effects, often I found from at least historical information is that patients, they'll be taken off of it. And local side effects are actually very common and quite expected. We are giving them a decent dose under their tongue or in their arm of what they're allergic to. So to have some side effects actually common. And so the best thing to do is warn them about it. Pre-medication with oral antihistamines, I do that for almost everybody, but it's patient specific, practice specific. I ask them to come in 2 hours, to have their antihistamine 2 hours before their appointment to take their first tablet, and then probably continue to take them for at least the first 2 to 3 weeks. Biggest risk is asthma flares. So, and anybody who has a history of asthma, I make sure they're on their preventer prior to starting for at least 2 weeks, and not using sort of Ventolin 3-4 times a week at rest, things like that. I won't allow them to start. The risk of them having a flare-up of their asthma at roughly 2 weeks is just like any other flare of the asthma, whether it would be viral. So you have to warn them about that. And we treat it the same way. Increase your preventer for a couple weeks, back down once the flare is done. Having a good contact in your office is probably a really good idea. So they have somewhere to say, hey, is this normal in my first month? Because you do get a lot of people who are contributing, going to try and contribute every little thing. Oh, I've got a headache today. Is that the immunotherapy? And you're like, well, you've got one headache a month. Do you normally get one headache? And is it common? And probably not contributable, but sometimes there are side effects, which I have another slide for, that are a little trickier to negotiate. And then always making sure that they know if they've got any major dental work. And when major, I'm talking more like wisdom teeth taken out, where you've got a big gaping wound in your mouth that needs to heal. You might want to make sure. Sorry, my internet. I'm getting a internet's unstable. So you dental work, especially like I said, the wisdom implants and things like that. So these are the hard ones, and anyone who already is pursuing therapy can actually end up taking patients off of it. These are little tricks that first couple of weeks to month. Having the tablet is easier with the a pill cutter with the tablet form, but if you're using the wafer, then maybe trying to crack them. And you do sometimes waste half of the wafer because it starts to dissolve, but often if you can get them doing that for 2 weeks, you're able to move it up. If you're using the Allergen's tablets, I my rep to up for 2 full weeks or the kit so that they can increase them up until they can tolerate it. Child's formation of histamine syrup sublingually and holding it there as long as letting them swallow it, waiting 20 minutes, pop the tablet can also decrease the local reactions without worrying about the efficacy of the tablet. When they have severe itching or irritation in the esophagus, I have them hold the tablet really long under the tongue, longer than they normally would, even up to a couple, like 3 minutes, and then spit it out, and then go back to trying to swallow after the first couple of weeks, and that often settles down that pruritus after their nausea, take stomach help one the meal, and of course severe asthma. Sometimes that this isn't very common, very rare, but with patients with really terrible asthma, sometimes I'll start them on a lower dose, like the drops, where you can titrate the pumps, and then swap them over to the tablets once that tolerance is achieved. So non-allergic rhinitis, this is where things get tricky. We're moving into the harder to manage patients. Everyone has that over 30-year-old who is allergic to perfume and jasmine and lilies, and everything in their house is hypoallergenic, and they've had to move jobs because Sybil's perfume was just too much for them to tolerate. They've no, the husband can't use any aftershave deodorant, nothing, or vice versa, the wife. And this is often environmentally based. They've stopped drinking alcohol, mostly wine first, and then they've been moved on to other things because they just can't tolerate anything. often show them the list of the upper respiratory irritants, and they can list in far like a few of these, including a lot of the weather changes, the humidity changes, cold air, high pollution. So you know, you mentioned anyone who lived in Sydney in 2019, 2020, they had to go during the bushfires. Oh, it was miserable, because that, of course, is not something we're allergic to, but something that much bother the non-allergic patients. In general, they do onset later than allergic rhinitis. It's usually irritant based. They often think it's pollen because it's coming on the wind, but it's actually not what's coming in the wind. It's the wind on its own that can actually be triggering them. The true non-allergic patient won't have a past history of allergic rhinitis. They didn't get any symptoms until they, you know, turned 30, 40 years old. And even though postnasal drip and throat clearing could be a complaint in an allergic patient, and I'm sure I don't have to tell you this group, when you hear a patient come in, you're the first thing that says, "Doc, please, I cannot taste anything," before they've said anything else. You're thinking obviously sinus disease. Well, when someone comes in and the postnasal drip and throat clearing, that's my main complaint, I'm thinking they've got a good component of non-allergic rhinitis going on, as well as possible other things as well. But the true non-allergic patient won't have history of. For those patients, I often tell a combination therapy, or add in the capsaicin therapy, which Cynol or Capsinol. Again, put the link to those websites in the appendix just in case. And yeah, see how they, because a lot of times it's just reassuring them and educating them that helps as well. So mixed rhinitis, this is where you got coming in of that older age group again saying, but they've all gotten very worse. And truth be told, sometimes we are seeing that just because climate change and stuff is worsening things with pollens and dust mites. But it can also be the addition of non-allergic rhinitis triggers in that patient. So you come out, if it's somebody who said, "Oh, I've moved to Sydney from Canberra and my allergies have gotten worse," then maybe there was somebody sensitized to dust mite who just got a walloping bigger dose of it by living in Sydney, or vice versa from Sydney to ACT or somewhere with a higher pollen count. But it also could be that the addition of all these other non-allergic triggers have just worsened their disease. Good education is required here, because often they don't realize where their exposure is coming from and thinking, "I dust my house all the time." Well, that's just triggering them, as opposed to trying to remove dust mites, which is what they're, you know, what they think they're doing. Often need a trial of maximum medical therapy and send them away and say, this is what could be triggering you in the non-allergic world. This is how dust mites can trigger you. And if you think it's pollen and it's July, it's probably not pollen, because nothing's really pollinating in that 1 month, you know. So things like that can help let them identify what's triggering them. And then when they come back, they, at least in my experience, say, "Yes, you're right. It is non-allergic that are far worse. I emptied the vacuum the other day once." Or they come back and say, "Yep, that dust mite's still a problem, but I have identified where my non-allergic triggers are." And so they might still actually benefit from desensitization. But I often counsel those patients on the probability of using nasal spray in the future to continue to treat their non-allergic triggers as well. So for instance, my humidity barometer changed patients in Sydney often are on it in the summer period of January, February, and then they can go off of their nasal spray for the rest of the year. Where patients who are more that sense and smell irritation, just use it sort of PRN when the things are bad or pollution's bad, or back burning is happening, things like that. So then moving on to another big diagnostic problem, the potential of localized allergic rhinitis. So to have a great cause and effect. Yes, every time I dust, every time I vacuum, when I grab a jumper out of the cupboard, I sneeze 3 times, I get a runny nose, I block up, and you do skin prick test and it's negative. You do the serum specific IG, it's also negative. And it poses a really conundrum on how to manage these patients. Obviously, you have the ability to patient testing, that's great. But we were doing it for a while in our rooms, but it is very time consuming for our technician, and we're you know, with COVID, and I think we just got so backed up, we just stopped doing them. But history around with antigens. One of those big red flags is I got with these great combination sprays at all. You got to kind of think about things because you want them to have some benefit, just like any allergic rhinitis patient would have that's got a atopic picture. So overseas, they can use basal activation test, which is a blood test, which shows basically the activation of the basophil at the time of a trigger. It's quite difficult because the blood test has to be 24 hours, less than 24 hours old, and they have to know exactly what you're looking for: house dust mite, grass pollen, etc. Unfortunately, they're not. It's just not offered here because they're really expensive. But you will read data from overseas that they're using the BAT test, and we do. Probably, if we ever get it, it'll probably be used for food testing before it is for allergy anyway. As far as the reimbursement for getting it done on the MPS. And in my practice, this is again not this is N-on-1 evidence-based. This is just what I do with these potential non-allergics. First of all, maximize the medical therapy and see what their response is, educate them on non-allergic triggers, often they don't know them. Consider a trial of immunotherapy antigen specific in adults with consent. We'll tell them when you're over 40, I'm probably not going to turn you allergic to dust by giving you dust mite immunotherapy, but it's going to be relatively expensive, and you might get absolutely no benefit, and probably going to look at least minimum of 6 months on it before we even know whether you really are going to benefit from it. In children, I have a little bit less of a less comfortable giving them immunotherapy without a positive nasal provocation test. And if they're really young, there's a good chance they just haven't turned atopic yet. And so I medically manage them. I often tell, and I don't, again, need to tell a group of ENTs, the most important thing here is that we keep this child's nose patent and working, mouth breathing and having everything. So using a nasal spray, and we'll keep on retesting them and watch this and start antigen immunotherapy when they're older. So it is a bit of a you know, how everyone does a bit different. But that's just what I do in my practice. So, oh, well, wow, that was quick. That's the appendix. So this is basically all the references that I've in there. So the multi-site, sorry, the serum specific test booklets, and the Rhinol and the Capsinol, capsaicin spray. Obviously, get it made up. Than these pre-made ones. Rhinol is available much easier in Australia and New Zealand. It's stored here, so it comes quite quickly. Capsinol comes from Europe, but it does have the extra strength version of it, which is what the Cochrane review and the trials used to do it. Was so sometimes I start them on Rhinol just because it comes quick and get them to order the extra strength if needed as a second line when it's coming from Europe. So I do hope that covered most of what everyone wanted to hear. If there's any questions.
Jess, thank you so much. And if you're happy just to leave that up for a little bit longer in case people would like to have a look at those links. But while anyone would like to look at those links, are there any questions at all from any of the members of the audience? You can either unmute yourself or put it in the chat. We'll give you a few minutes to have a look at those websites. And this will go on to the ANZRS website. Jess, we lost you a few times, so we might talk about re-recording it, but it will go up onto the website at some point if you wanted to go over some of this talk. if there are any questions at all.
Yeah.
Otherwise, Jess, I might just get you to stop sharing now, if that's okay.
Good. Sorry, just trying to get to it. My mouse is being a bit funny. There we go.
Awesome. Thanks, Jess.
Good.
So, are there any questions at all? No? Perfect. Well, Jess, you've answered everyone's questions in one fell swoop. So that's brilliant. Thank you so much. I'm just going to let you guys know about our next webinar. I'm just going to find the... All right, I'm just going to share that. So we'll over. So our next webinar is in 2 months' time, and that's going to be Professor Alki Soltis, the President of the Australian and New Zealand Rhinologic Society. He's going to talk about long-term treatment algorithm for CRS patients after surgery and where biologics fit in with these patients. And that's, again, the link is on the website and as well as the title. And we'll continue to update the webinar series as we get our topics filled for the rest of the year. But if there are no more questions at all, we will close the webinar for tonight. And Jessica, thank you so much for